Alright, moving on. Anemia. We want to allow the patient to assume a position of comfort. Transport to the closest appropriate facility. Consider a rapid transport if anything develops, such as hypotension, abrupt changes in consciousness, and other significant perfusion inadequacies. So we have leukemia. Leukemia is a cancer that develops in the lymphoid system. Blood cells, particularly white blood cells, develop abnormally and excessively. Leukemia can cause anemia, thrombocytopenia, decrease in platelets, and leukocytosis, which is an increased number of white blood cells. This is when the body attacks itself. Chemotherapy typically leads to leukopenia. Patients experience frequent bleeding, bruising, infection, and fever. For leukemia, can be classified as acute or chronic. Chronic leukemia develops a lot more frequently in people who are 65 years or older. And acute leukemia is bone marrow replaced with abnormal lymphoblasts. In chronic leukemia, abnormal mature lymphoid cells accumulate in the bone marrow in lymph nodes, spleen, and peripheral blood, typically found by chance during routine blood tests. So survival depends on several factors. What stage is the disease detected? Is the patient's underlying medical condition response to the treatment? Leukemia is treated with chemotherapy, radiation therapy, and in most cases, treatments result in remission. Children with acute lymphocytic leukemia have a 5-year survival. It's greater than 85%. Use appropriate standard precautions, including glove, masks. The patient could be immunocompromised. Patient's presentation depends on stages of leukemia. Current treatment, patient may be presented with fatigue and headaches. Could also have fever, bone pain, diaphoresis, feeling full, soreness in the mid part of their chest, unexplained bleeding. Monitor all basic vitals and also their cardiac rhythm. They might have hypotension, tachycardia is often present as well. So we want to provide airway support. Oxygen therapy is appropriate. IV fluid therapy, analgesics may be needed if they're in extreme pain, and the patient may need constant emotional supports because this absolutely sucks. You may be called because the patient's condition has deteriorated and the loved ones are uncertain about what to do. Discuss the situation with medical control. Document all findings before leaving and have a refusal and release form if transportation is declined. Be alert to rapid changes in the condition. If you transport, be aware that the patient could go into arrest. Make sure that you understand the patient and family's wishes about what to do. Lymphoma. So, groups of malignant diseases that arise within the lymphoid system, classified into two categories, non-Hodgkin and Hodgkin's lymphoma. Non-Hodgkin lymphoma can occur at any age. It can be hereditary and may be characterized based on progression, very slow, indolent, aggressive, or highly aggressive. Indolent disease may never leave the lymph node system. Highly aggressive may affect multiple organs in a short period of time. Hodgkin's lymphoma. It's painless. It's progressive enlargement of the lymph node glands, most commonly affect the spleen and the lymph nodes. It's highly rare form and suspected to have some hereditary components. Incidence at two peaks, 10 to 35 years of age and in late life. Possibly no symptoms for years, but then could include night sweats, chills, persistent cough, swelling, loss of appetite, and generalized itching, fatigue. Assessment. Lymphomas require specialized levels of chemotherapy or radiation therapy. How well the disease responds to treatment depends on the stages of the disease and its classifications. During assessment, ask questions like, what type of cancer do you have? What type of treatment are you receiving? And signs and symptoms may include pallor. as well as feeling hot, cold through areas of the body, inadequate perfusion, low blood pressure, and abnormal rhythm. Where's ease? So pain management needs to be aggressive, treat inadequate perfusion of fluid therapy, and provide supplemental oxygen. Treat any abnormal heart rhythm. If the condition does not improve or deteriorate, initiate rapid transport. You may be called to offer support, but not transport. Be supportive. Support your finding with medical control. Explain the situation and the options to the patients and family. Let them make their decision. Polycythemia. Pathophysiology. Polycythemia is the overabundance or overproduction of red blood cells, resulting in increased blood viscosity and volume. This can result in congestion of tissues and organs. Hyperviscosity of the blood increases the risk of thrombus in formation. Polycythemia can be caused by a rare disorder originating in a single stem cell. Existing disease such as heart failure or hypotension. Living in high altitude areas for long periods. Polycythemia may lead to other conditions such as strokes, transient ischemic attacks, deep vein thrombosis, pulmonary embolism, myocardial infarction, headaches, abdominal pain. Clinical treatments may include phlebotomy to maintain the hematocrit levels, which is what we were talking about earlier. Less than 45% in men and 42% in women. Other treatments can include cancer type therapy. Findings may vary widely and can include hypoxia, altered levels of consciousness, respiratory distress, changes in peripheral pulses, pulse rate, and skin color, tachycardia, purplish skin, red hands and feet. Note that the extent of and duration of dyspnea. Patient may experience uncontrolled itching, pruritus, and the patient can also note changes in the skin temperature obtained during medical history. Management. Pre-hospital treatment should be initially the focus of the chief complaint, although if underlying pathophysiology may be polycythemia, the patient may experience a different medical emergency. Otherwise, provide supportive care and transport an appropriate facility. Administer oxygen as needed. Establish IV access for possible pharmacological conditions. Disseminated intravascular coagulation. Pathophysiology may be caused by a number of life-threatening conditions. So first stage could be free thrombin, fibrin deposits in the blood, increased platelets begin to aggregate. Defibrination, breakdown of fibrin clots occur. Second stage of uncontrolled hemorrhage result from the reduction of the clotting factors. High mortality, especially in acute cases. Up to 65% mortality and related to uncontrolled bleeding, hypotension, and shock. Identify signs and symptoms associated with disseminated intravascular coagulation or progression towards it. Patients may have episodes of respiratory difficulty, signs of shock, skin changes. Hemophilia. Pathophysiology. Hemophilia is a bleeding disorder in which clotting does not occur or occur insufficiently, usually associated with X-linked recessive inheritance pattern. This is classified into two primary types. Type A, 2 levels factor, type 8, antimorphilic globulin and antiphilic factor. Type B, deficiency factor 9, plasma thromboplastin component of the Christmas factor, is primarily found in males. Signs and symptoms are the same in both types, include acute chronic bleeding, spontaneous intracranial bleeding. What is this? Pallor, weak pulse. myeloma. So pathophysiology of myeloma. The number of plasma cells in the bone marrow increases abnormally, forming tumors in the bone. Impairs normal bone marrow function, decreased RBC, WBC platelet formation, and results in anemia and susceptibility to infection. Neoplastic cells may also accelerate protein development in the bloodstream. This could lead to organ failure. The disease occurs mostly in patients older than 40. As the disease progresses, patients may have weakness in the bones, result in spontaneous fractures, pain in the bones and back. And it could, in advanced cases, chemotherapy and other anti-cancer type treatments may be given. Adhere to appropriate standard precautions, including masks, gloves to keep the patient's multiple myeloma safe. Findings depend on the stage and disease. Early stage complaints may be fatigue, mild pain. Later stages could be evidenced by unexplained hemorrhage, significant weight loss, frequent bone fractures, as well as pain in various locations. Management would be IV fluid, pain management, supportive care, no assumptions that the patient is ready or going to die, definitive care. Transfusion reactions. Transfusion reactions occur in approximately 0.2% to 10% of blood transfusions. Reactions are similar to anaphylactic reactions. It occurs rapidly and acutely, can cause severe circulatory collapse. Monitor the patient receiving blood transfusions very closely for the first 30 to 60 minutes. Determine the patient's blood type and type of blood received, and transfusion reactions occur when the patient receives a blood type different than his or her own. This table shows ABO RH blood types and referred to alternative donor types. So, O negative is the universal donor, and AB, let's see, which of these? There we go. AB positive can receive every single type of blood. That is the universal receptor. So this is one of the rarest bloods that you can get. Unfortunate for you, but you can provide it to anybody, and I'm O positive. So the greatest threat to a patient during a blood transfusion is a hemolytic reaction. It's primarily caused by incompatibility between the recipient and the donor blood. The recipient's immune system is activated by the donor blood and destroying new RBCs. They could have a febrile reaction, usually benign, most common complication, and treated with an antipyretic and observation. Allergic reaction. Anaphylactic reaction and preservatives or other agents in the product being transfused usually occurs within the first few minutes of the transfusion. Classic signs and symptoms of the anaphylactic state. Transfusion-related lung injury. This is a non-cardiogenic pulmonary edema caused by increased capillary permeability post-transfusion. Treatment is focused on supporting your ABCs, your airway, your breathing, your circulation, and circulatory overload. Circulatory overload typically occurs in patients with pre-existing cardiomyopathy or ventricular dysfunction. Treatment consists of relieving the system of its excess fluids through diuresis and process of oxygen, nitrates, and morphine. Bacterial infection, typically a result of a poor blood product handling contamination during the infusion process, can often lead to systemic sepsis. We want to manage it by the severity of the reaction correlates to the amount of blood volume transfused. Care is centered on immediately stopping the transfusion, providing hemodynamic supportive care to counteract the shock, maximizing kidney perfusion. A patient that's hemodynamically unstable condition requires early invasive monitoring, vasopressors, promotions of diuresis, and isotonic fluids with a loop diuretic furosemide. Dopamine may be helpful. High flow oxygen should be administered, and administration of epinephrine and diepinephrine should be considered. That's all she wrote.